Well, thank you very much for having me. It is such a delight to be here and a great opportunity, as Stephen said, for me and my daughter to have to see Britain and Wales, but importantly, an opportunity to speak with you about this topic, which is near and dear to my heart, and I've spent many years focused on issues related to patient safety, safety culture, safety leadership. And people have begun to ask, what have you learned? What are the things you can teach us about how to transform culture in organizations, how to help people lead this transformation in order to make our healthcare facilities safer? So I'm going to try and speak with you about that tonight, and we'll see what we can illuminate. I have not prepared enough remarks to fill an entire hour, so I would welcome you to interrupt and to add questions or comments or suggestions, and certainly at the end I think we'll have some time to talk. So let's begin. I've organized my remarks around guiding principles. What are the guiding principles I would suggest based on what I've learned so far in the study of safety culture in healthcare organizations? And so in the next, let's say, half an hour to 45 minutes, I'll describe 6 guiding principles that I have condensed from this work. The first one, if you will flip, I call Contemplating Culture. These comments come from one of the first in a series of important Institute of Medicine reports that you're probably very familiar with, to err is human. I put it up here because I love to show lots and lots of words. What I want you to take away from this is it's not about lots of words on the page. When I see things like this, and if you begin to read it, what comes up for me is the cartoon. Do people here know the Peanuts cartoon, Snoopy and Friends? And there's a scene often where the teacher of the children start to speak, and she evolves into the wah, 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 wah kind of talk. And what I tell people about culture is that it's not about the words on the page that's important. What's important, if you show the next slide, is really thinking through and understanding what we do around here. So culture in the most basic colloquial terms is how we do things here in this organization. And the real value of trying to understand and focus on the culture of the organization is that it's your own. So what's important about a conversation is that you have it, you think about and you discuss with your colleagues what kind of culture do we have here, and then move that toward what sort of culture do we want to have here in this organization, and what are the sorts of things that we might need to do in order to get from where we are today to where we're going. Because all too often, and I think increasingly as there become a proliferation of experts around organizational culture, we feel this need of taking on the latest buzzword. It should be a safe culture, or it should be a just culture, or it should be a blame-free culture. And unless we have that dialogue around really what sort of culture we have and what sort of culture do we want, we never get to the point where it becomes our own. So one of the examples that I like to share with students in my own course, I teach a course at the School of Public Health at Harvard called Healthcare Organizations and Organizational Behavior. And I actually start the course with a case around Johnson & Johnson, the pharmaceutical company. What I like about that case is it gives us an example of a company that really took a lot of time to go to develop its own really strong culture. And the way they did it was to create a vision and values statement. And it was on the books for many years. And the leadership of that organization at a certain point felt like it was no longer the way that organization did things around there. So he took the values and vision statement and he shopped it around to first the senior managers and then the next level of managers, and he met frequently with the frontline workers, and he said, how would you change this statement to better reflect what it is we do here, or what kind of organization we want to be? So the exercise of actually using that vision and value statement to ask people to reflect was an exercise of building again, renewing their dialogue around a culture in order to create a strong culture that was focused very specifically on the kind of organization Johnson & Johnson wanted it to be. And I would argue, Johnson & Johnson has very recently had some problems around some of their products. Well, this conversation went on around the time of the Tylenol problems, and if people remember what happened then, there was an issue related to tampering of Tylenol, and Johnson & Johnson spoke out virtually immediately with a recall that people felt was a model in that organization, and it was right around the time that these conversations were occurring. And I would argue that subsequent to that, and more recently, coincident with times where Johnson & Johnson has not been so forthcoming in terms of recalling products when there have been performance problems, that the conversation around their mission and values, the kind of culture we want and the kind of culture we have, probably lapsed. So that's what I mean about contemplating culture. There are, as we know, and as you probably have heard, there are characteristics that we think about when we think about what kind of organization we can or should have if we want it to be a strongly safe culture that I would offer for consideration for your organizations. First is psychologically safe. Do people feel safe in this environment in order to speak up and talk about their mistakes, to take interpersonal risks in order to speak out about things that they're concerned about without being fingered as a whistleblower and criticized for that reason? Do we have a learning-oriented culture? Is the culture one in which people really recognize that mistakes can happen and emphasize in the moment when a mistake does happen the learning rather than trying to suss out blame? In one of the early studies in my research on patient safety, I'll never forget a group that I encountered where over and over again I heard about the story of a nurse who reported a problem. We have Pyxis machines. I don't know if you have Pyxis machines here, where these automatically dispense pharmaceutical products. And she noticed that there was a narcotic drug that was missing from the Pyxis machine. She reported it. And what happened to that nurse, rather than being thanked and congratulated and highlighted for her good work, the police were called in. She was called to the front office. She was basically dragged out in a very visible show of blame. And that story was one that was repeated to me over and over again. And I finally asked, well, when did that happen? Well, it was like 5 years ago. So it's remarkable the way in which a lack of a learning orientation, sort of these one instances in which there is, an opportunity to really either demonstrate that you're learning oriented or not, make a big difference and a lasting difference. Systems orientation sort of married to that, the recognition that people and processes are connected in ways that you need to reflect upon when you are making changes, so that you make sure that you don't make a change on the left hand only to cause a problem on the right hand, and then to focus on foolproofing the systems rather than training the individuals when errors do occur. And then finally, safety leadership, which I'll talk a lot more about. But when I say leaders, modeling, I mean both clinical and non-clinical leaders, and I assume that in this room here I have a mix of both of those. But is our organization one in which people at all levels of the organization and all stripes of healthcare professions model our commitment to trust and respect of one another as leaders and as colleagues in the organization in ways that make people feel like they don't need to fear taking risks in order to speak up. So contemplating culture is the first of my guiding principles. The second one, if you'll move ahead, thank you, is I call embracing leadership. So this is a really important one because I don't feel like people in all aspects and all elements of healthcare organizations do this with regularity. So when I say embracing leadership, I'm talking to absolutely everyone in this room, everyone up and down the hierarchical levels of authority within the organization and across professions, and I'm even talking to people from both within and outside of a healthcare organization. So very often we confound, and I do the same, we confound the terms leadership and management. We confound the terms leadership and leader. When I say leadership, I mean an act. It can be an act by absolutely anybody in an organization, regardless of their position. So all stakeholders have the power to act, and I would argue that all stakeholders bear some responsibility in acting. I very often hear from the non-clinicians, there's only so much I can do because I'm non-clinical. I very often hear from the clinicians that it's not my job. I'm not a manager, I'm a doctor, or I'm not a manager, I'm a nurse. I don't need to be the leader. What I tell to the physicians especially, but this is really true of all clinicians, but the physicians especially, they really can't escape the fact that de facto they are leaders. They are seen as captains of the team and people look to them. And what I tell them is that it can be a real benefit to them, and it can also be to some extent a burden. I had a friend who very quickly rose through the ranks of his own company to become the CFO of a biotechnology giant in California, and I'll never forget sitting down with him shortly after he rose to that position, where he said to me, I really have to watch now what I say, because people pay attention. People pay attention in ways that made him uncomfortable, but he started to embrace that and reflect on ways that he might say things to move people in the direction where he was hoping that they would head. Physicians have that same opportunity. People watch them. They have a heightened sensitivity to the words that they use and to their actions, and others take cues from them about the behavior that's desired within the organization. It's true of physicians, and it's true of people in roles of authority within healthcare organizations, but as I said, particularly among the physicians. And it means that small actions, like the one my colleague Bruce was describing, small actions can have big consequences, but it also means that they present big opportunities. So a word of thanks, a word of encouragement can really go a very long way. So physicians who aren't necessarily the ones who want to be out in front of change, if they see it as burdensome to take something on, by saying, gee, I think it's a really important thing to do, thank you for your efforts in this regard, actually have a lot more impact on others than they very often realize. And when you encourage them in that direction, they're very often eager to participate in that way. Okay, why don't we move forward? So in thinking about leadership, one of the things that I often find myself needing to do with colleagues is to speak with them about what I call updating their mental model. It's really a shift in mindset about what kind of leader are we talking about here. So here's my very basic depiction of what I mean. Very often in healthcare professions, people think about the heroic leader depicted on the left, the cape and all. But really, people who have been trained in medical professions are very often trained in ways that encourage them to be completely self-reliant, very authoritative in their decision-making, and not oriented to working together as a team. So it's very important to reset that mind shift. Fortunately, in medical training now, there's a lot more emphasis on team-based training and team-based care, so they're beginning to get it, but So maybe it'll take another generation, but I think that even the generation that is in positions of authority and power now can make this mind shift if they see it and think it through. And obviously we also see it. But what it really means, importantly, in thinking about problem solving and decision making, what we really need from effective leaders is for them not to offer the solutions, but to think about themselves as leading a process of asking the right questions. So very often by asking the questions, you can elicit a lot of ideas, better ideas, and importantly, if you can create consensus around those ideas, you are much more effective at implementing them. So the decision-making literature talks about when you want to come to consensus versus when you want to focus on approaches like devil's advocacy in order to make sure you get to the very best solution. Well, very often in healthcare settings, what's critically important is the implementation piece. And where the implementation piece is critically important, what you're after, what you're really seeking to achieve is sufficient consensus, the creation of feeling of sufficient input into the decision itself, into the solution to the problem, that people are bought into that implementation phase. So throwing out the authoritative, heroic leader model and focusing on, I'm a member of this team, someone who can encourage others to participate and to draw the best out of others, is the kind of mental model that we encourage people to shift toward. So I wanted to focus on a few of the studies that have done what I think is the best work, thank you, in leadership and what we know from them about how to be an effective leader. So this table is a summary of some work a colleague and mentor of mine, Amy Edmondson, has done out of Harvard. She studied among cardiovascular surgeons an attempted transition of using open heart surgery versus using minimally invasive cardiac surgery. And she studied what the surgical teams that were able to accomplish that shift did versus the teams where they weren't quite so successful. And she found that the groups that were successful were the ones that were able to assume what she called a learning orientation, what I call a learning orientation. So those groups varied on a couple of really important dimensions. So when you introduced the change, how did you go about it? The groups that were labeled the lower performers had a performance orientation in that they viewed the situation as essentially what we always did. So here, recall, we're going from open heart surgery to minimally invasive cardiac surgery. They thought it was basically the same thing because they were still operating on the heart. But if you think about kind of the massive change that is required in how you go about performing that procedure, you can see it as very different. So the learning-oriented groups viewed that change as something that was challenging, full of unknowns, opportunities for reflecting on how we can do things differently and better. The goal, according to the high performers, was therefore learn as much as we possibly can in order to know what to do better and best next time. So not just about what we can learn about implementing minimally invasive cardiac surgery, not just about this particular case, about the next case, not just about this particular shift in what we're doing, but about the next intervention that we want to try to implement. How do we learn about how we learn within this group? Whereas the performance-oriented lower performers really just focused on, let's get this done, let's get this implemented and move on to the surgery in order to perform as much surgery as we possibly can. The view of themselves as leaders in taking on this transformative change was really different. So the lower performers viewed themselves, as I described, the sort of heroic leaders as basically self-sufficient. We know what to do. Just give me the tool and I'll operate. Whereas the leaders in the higher performing groups, the learning-oriented groups, felt that they were important for getting the work done, but only one of a constituent group. And their view of others, correspondingly, was as partners. So they valued the other people in the team. They viewed them as important to being able to implement the change. Whereas for the lower performers, they were basically subordinate to the surgeon leader within the team. Based on that work, but also based on some of my own work related to examining how groups implement surgical checklists in operating rooms, and on additional work coming out of Yale University, where people looked at higher and lower hospitals in terms of their ability to achieve low rates of AMI mortality, so mortality following heart attacks. We all essentially came up with the same process for how to go about learning when you're trying to implement a change. So we call this kind of a learning-oriented implementation cycle. But basically it follows the same kinds of 4 steps. The first thing you want to do is enroll the group of people who are going to be involved in the project. So what does enrollment mean? Enrollment means selecting the right people. It means selecting people who have the skills and the expertise, but also the attitude. We want to be among the group that leads this effort. Letting them know that they've been selected as part of the group that's going to trial and experiment and learn as part of the work. And focusing with them on what they're trying to accomplish. Everyone should share an understanding and the objective. So, you know, pull them out as special. And then the preparation step is practice. So you can't really do anything well without practice. And it was remarkable in the safe surgery work, in the cardiovascular surgery work, and in the AMIs. When they went to implement these changes, some people would just leap, assuming that it was so little different from what they'd always done that they could simply do it. But instead, if you practice the behavior offline, when we do surgical checklists, what we have people do is go into a room and, you know, have somebody lie down on a table or not, just sit around the room and read through the checklist. And it's remarkable, the actual saying it out loud and talking about what was comfortable, what was uncomfortable, and how you might do it differently made a remarkable difference in people's ability to do it under the pressure of a surgical case. And so practicing that behavior together, preferably, in order to think through what you need to make that more successful. And then trialing it. So the trial piece happens after the practice piece. Trialing means doing it for one case, one time. And then reflecting on it, lastly, to discuss what it is we learned from having trialed it. Looking outside to understand what others have learned in also trying to trial it to see what we can adopt, and then having that be kind of an iterative cycle where you continue to enroll more people and test them and to roll it out. So it's a very simple process, logical, makes sense, and it's remarkable how infrequently that kind of a process gets implemented. My last point about leadership is directed to those who are eager to lead. Don't forget to partner. So it's remarkable the number of times people want to do something, they're very invested, they're really passionate about making the change, and they forget about all the other people that they need for trying to help them go about it. What I say is no amount of time, interest, information, skills is enough for affecting a complex change that is going to cause different pieces in systems and processes to change, regardless of how passionate you are. So you need partners for a variety of reasons. You need partners for creating that guiding coalition that is going to help you break down barriers when the systems and processes outside of your control need to change. You need partners to help you build that consensus because your social network may not extend to everyone within the organization. And you need to empower others in order to act so that they're not constantly feeling subordinate to you, so that they're feeling a part of the change and therefore willing to enact it themselves. So for all those reasons, and John Carter's work goes into this extensively about why you need others when you're trying to affect a complex change. So the kinds of changes that you may need are depend on what your own skill set looks like, but very frequently you need some combination of people with technical expertise. You need people with project management expertise. You need people with administrative capacity and expertise to get things done, and especially, and very often people forget, the need for expertise in interpersonal dynamics. It's remarkable how often we fail to reflect on our inability to have a decision-making process or a problem-solving process that is truly effective. I was reflecting in a talk that I was giving this afternoon about a nurse who in a conversation said, God, I'm an experienced facilitator, and my group never calls on me to facilitate a conversation, and we always end up with decisions. She called them decisions that fail. But people with interpersonal dynamic expertise who can reflect on the fact that maybe we jump to that decision a little bit too quickly. Maybe did you notice that the person over here had a point that really didn't get integrated into the conversation? Maybe that's information. It may not be shared information, and that may be why it was ignored by the group, but it could nevertheless be valuable, so maybe we can revisit it. You don't have to hire a consultant who is an expert in interpersonal dynamics. Sometimes you can simply identify someone to say, could you please just watch? Look for those people who are trying to speak up and who aren't really getting a word in edgewise. If you can agree within your group that it's important and can designate someone to take that role, can really help. So we've identified in our work that and others have as well, the ability to partner has distinguished successful improvement efforts, and I'll give you just one example if you want to go on. So this comes from work that I shared a lot more about this afternoon, so apologies to the people who've seen some of this before. But I studied hospital management teams, and we wanted to understand the dynamics in the higher performing hospital teams and the lower performing hospital teams. And we defined performance in that box down at the bottom on the left according to two measures. One was the ability of the groups to implement a quality improvement project that they identified, and the second was staff perceptions about the leadership of that group. And when we identified the higher performers, it was abundantly clear that their ability to partner was one of the key factors that was going on. So the higher performer in green, typical of that type of group, an example here, someone saying, everyone is heard, everyone has an opportunity to think of something else that no one has thought of. So this group really took the time to allow people to speak up and to contribute. The lower performers, we saw very little partnering of that type, and the senior-most leaders in those groups never reached out to the others in order to ask for help. And so here in the red is a much more common kind of quotation from the lower performing groups. Here, this gentleman says, maybe it's just my temperament, but sometimes democracy is good but not good enough. Sometimes you just have to say, that's what we're stocking. So in this case, very little partnership going on, a preference for skipping to just having the decision made without a reflection on the importance of the process for gaining people's willingness to buy in to the implementation phase, which, as I say, in healthcare is probably the most important piece of the dynamic. So third guiding principle. Third guiding principle is focus on problems. This may seem counterintuitive because I started out by saying I'm going to talk about how to change culture. But I like to focus on this one because I can't tell you how often I hear from people, we don't have time to focus on culture, we got a lot of work to do. And I giggle a little bit because I say, how do you think you're going to change the culture? You can't just sit around a table and work on culture. You have to work on something that's meaningful and important in your organization that is a problem that's right out in front of you. You can't you can't miss if you identify a problem. Very few problems, some lend themselves to purely technical solutions, but most problems these days in complex organizations with groups of individuals include elements of culture that come up and that are really important. So if you focus on changing, fixing a problem, solving a problem, you will, over time, be working on your culture. And it is, it often, by highlighting this fact for people, it becomes such a relief. Oh, I can focus on a problem that's important here? Of course you can. Of course you can. Problem solving gives action, gives focus and motivation to the work that you're doing, and it's critically important. So on the next slide, there is kind of an image of the dynamic of how this happens. Let's skip ahead. So this is a very modified schematic that I have drawn in connection with a systematic review that I recently did in looking at interventions that lead to performance improvement related to medical error reduction. And I tried to describe the relationship of safety culture, safety climate, and how that evolves over time. But for our purposes, I wanted to use it to illustrate how this process of focusing on a problem leads to culture climate change over time. I'm going to talk about a nurse named Beth. I ran across Nurse Beth as part of my work on surgical checklists. So Beth was interested in safe surgery. She was nervous about how surgery went in her hospital. And this is a frontline nurse. She read Atul Gawande's book on the checklist manifesto, and she said, I really think checklists are the way to go. And without any particular level of authority within the organization, she acted as a leader. She went to a surgeon who she had a good relationship with, who she also saw as someone within the organization to whom others kind of looked up. And she said, would you help me? Would you try this checklist? And he said, don't really believe in it, but for you, I'll do anything. Of course, I'll try. So Nurse Beth and her surgeon said that they would use the checklist. The others on this particular surgeon's team saw this surgeon's willingness to use the checklist. They trialed it as a group. And in trialing it as a group, initially, they sort of just did it. They read it. And if people are familiar with how checklists works, you stop at 3 phases. One of them is the general timeout, where you check for the right patient and the right procedure, et cetera. But the third step in the process is a debriefing. And the debriefing allows people to talk about, was there anything that could have gone better? And in that discussion, someone said, you know, the same pair of, the same scissors that are always broken, were broken again. Can't we do something about this? So Nurse Beth said, here's an opportunity. And by the time the surgeon had his next case, she'd fixed that piece of equipment. And surgeon notices, great. The group, he with his next surgical team, tries the checklist again. This time he's a little bit more motivated to do it, and he actually takes some time. And in the initial portion of the surgical checklist, he does a pretty thorough briefing of the case. Well, that time it was important that he did it. So what happened was that this was a procedure that the hospital always performed on one side. But this surgeon, in conversation with the patient, had determined that in this particular case, because of patient's prior history, that patient should have it done on the opposite side. Well, the message didn't get through to the anesthesiologist. The anesthesiologist had prepped for the original side, the side that they always do. But because of the briefing, the anesthesiologist, because of the attention to the briefing, the anesthesiologist says, wait a minute. I'm preparing for this side. Did you just say that side? So they were actually able to prevent a wrong side surgery in that particular case very quickly after they began the process of trying to implement the surgical checklist. So then what happens? So there's a hard outcome in their mind about performance improvement as a result of using the checklist. So they go to their respective, surgical lounge and a physician's lounge, and they talk to some colleagues. And then more people agree to use the checklist. And because of the lore associated with this near miss, people actually start to pay attention to it. And more people do over time. And by having done the work of getting the checklist implemented, and there were lots of hiccups along the way, but by doing that work over time, slowly but surely, that culture changed toward one that I would argue is a safer kind of a culture. So that's what I mean by working on a problem that will ultimately affect culture. I'll have one more example if you advance the slide. This comes from work that I'm doing with primary care teams, groups of primary care clinicians who are trying to advance team-based care in association with efforts to become patient-centered medical homes. So as part of that work, they did a baseline study, a baseline evaluation that Qualis Health recommends. And one of the questions says, evaluate yourself according to this component. Patients are encouraged to see their paneled provider and practice team. And one of the facilities selects, positions themselves as a number 5, which means that they're pretty squarely the type of group that encourages patients by the practice team, but it's not a priority for their appointment scheduling, right? So not all their patients are getting to see their specific provider or their team. So if you flip to the next slide, here are some examples of what they do. So the question is, what's it going to take for you to move up one level on that scale? Is it going to take, what is it going to take? So they identify a few simple steps, which is definitely working the problem. And in doing it over time, they shift the culture to a more patient-centered culture. So they create a script for their schedules that says, do you want to see the PCP? Or do you want to see the care team? They create a policy that gives the patient the choice of having an earlier appointment with the an earlier appointment with any provider or a later appointment with the PCP if that PCP isn't available immediately. So they've got a script for people to use, very concrete. They've got a policy, also very concrete. It's a very specific step that can be taken, but that signals the patient-centered orientation of the organization. And then they implement a series of PDSA cycles, Plan, Do, Study, Act in the IHI model, of small steps that move the group toward utilizing the lower levels of nursing toward what it is they are licensed to perform in order to free up the patient's PCPs over time so that there's more availability for them for scheduling. So very small steps, working the problem over time with this overall goal to try to address the problem of we can't get the patients in to see their PCPs or even their primary care groups very often. How do we work on it? But in doing it, because of scripting what people say, creating policies that send the signal, and then over time working on iterative improvement around it, they shift the culture. And they do it in a way that builds capacity for people to work together to solve more problems, which is kind of how that cycle over time really begins to take shape and evolve. Okay, go ahead. So guiding principle number 4 relates to aligning systems and processes. And I'm speaking to everyone, but I'm especially speaking to people with the authority to make some of these changes. But the overriding point is that tradition, or maybe better said, inertia is an incredibly powerful force. We're like rubber bands. If we change, we are prone to snap right back into position. Exactly the way I tell my daughter she's got to wear her retainer. She just got her braces off, and if she doesn't wear that retainer, her teeth are desperate to get back into their original position. And in the same way, every time we make a change in a healthcare organization, people want to regress right back to where they were because it's easy, it's what they know, it's what they're comfortable with. And so making change stick is a really hard thing to do, and it needs to be reinforced until it becomes the new way we do things around here. And we always underestimate the amount of change that requires. And so very, not rocket science to understand the ways that our systems and processes might undermine the change that we're trying to cultivate. Some of these things are things that individuals can affect. Some of these things are things that organizations can affect. And some of these things, unfortunately, are things that, the health service will need to take on. And you can't necessarily do things about them. But the more that individuals at any level, so individuals can identify problems, can identify areas where processes or systems or policies contradict the change that you're trying to implement. They can encourage and support them. And people in positions of authority can actually take steps to try to change them. But very often our budgeting processes, our hiring processes, the performance management systems, and the monitoring and control processes, the what we measure, aren't aligned. And a lot of these things are things that we can affect. Are we measuring the things that we care about? If you care about team-based care, are you measuring individuals or are you measuring team performance? If you're interested in team-based care, what are the questions that you ask people when you interview them to hire them for a position? Do you ask them about how they've worked together with people before and how they rely on others? Do you observe the way that they interact with others? And then, of course, performance incentives are hugely important. Do you pay based on team-based outcomes, or do you pay based on individual outcomes? And sometimes we don't always have the authority for doing it, but it's remarkable, even where you don't have the authority to change financial systems, if you can measure team-based outcomes and reward people even in non-monetary ways for team-based outcomes, it can make a remarkable difference for people. All right, so I want to show another example, because this is a really simple way of trying to align not systems and processes, but language. So this comes from one of my favorite organizations where there was an almost total transformation of the organization to a safety-oriented culture. This comes from a children's hospital in Minnesota. And some people may have heard of Julie Morath, who now does a lot of speaking. She's at Vanderbilt these days, but she's quite an inspiring speaker in patient safety, and this is one of her brainchild. She codified a series of words, but anybody can use them. So what she tried to do is to identify words that undermined the culture that she was trying to create, and she basically outlawed them in the organization. She told people that these are words we're going to use and these are words that we're not going to use, and you can call anybody on using these words because they're not appropriate in this organization. So we talk about accidents or failures. We don't talk about errors, because errors imply fault. Someone is at fault, not systems are at fault. We talk about learning. We don't talk about judging. We talk about an examination or a study. We don't talk about an investigation, because an investigation implies something punitive. We talk about systems and the way systems cause problems, set people up for making mistakes. We don't talk about events that were caused by individuals. So all of these words reinforcing a sense that we are not blaming individuals, we are holding systems accountable, and we are focusing on what it is we can do to make our systems safer so that any individual within those systems can be effective at what they do. So fifth guiding principle I call relishing resistance. So here's another one of those counterintuitive principles. Especially clinicians cringe when people talk about physician resistance or clinician resistance. They say, I'm a good person, I want the right things for my patients too. So resistance is not the problem. I prefer to view resistance as a potential opportunity for making the improvement better. So if we recognize, if we believe that healthcare professionals want to do the best for their patients, and I really don't know a healthcare professional that doesn't want to do the best for their patients. And if we believe and if we assume that any intervention has the possibility for improvement, especially when you think about, the way the intervention needs to interact with how we do things around here. So any organization is different at the start, and when you impose some intervention in an organization, you really need to do it in a way that fits within the organization. So any intervention can be improved in order to make that fit work better, and not just at the organizational level, but at the individual level. So if you believe those things, then you can approach resistance with real curiosity about what is the rationale for that resistance, and can we use our understanding of that rationale in order to improve our intervention, to make it work better. So I'm going to do one more slide to explain more about what I mean, and this comes from Peter Sengi's work on organizational learning, and he talks about individuals having beliefs, assumptions, and values. Organizations, culture comes from organizational beliefs, assumptions, and values, but individuals have their own beliefs, assumptions, and values. And people apply those beliefs, assumptions, and values when they see data. So we all get data. Sometimes it's the same, sometimes we don't all see the same data, but we get data. But given our beliefs, assumptions, and values, we select the data that we focus on and then pay attention to. There's some brilliant films from organizational psychology. I don't know if people are familiar with them, but you can watch a film clip where people are playing basketball and they instruct you to count the number of times a basketball is passed across the team. And if you watch that carefully, you miss the fact that sometimes it's a gorilla who walks across the screen, sometimes it's a woman with an umbrella who walks across the screen. You can completely miss it, because you're focused on what you're focused on. And in the same way, given what we believe and what we assume and what we value, we focus on the things that are important, what we believe are important in the data that we see, because we're limited in what it is that we can take in. So we select the data, and then we apply our assumptions and values, and we interpret that data in a way that we interpret it, and based on that we draw our own conclusions. Well, if you believe that that's what's going on, you can see how easily someone with different beliefs, assumptions, and values, who may see a slightly different set of data, could come up with very different conclusions. And if you appreciate that that's what's really going on, it's very simple to assume and to understand how someone's conclusions might be very different from your own, and how it presents an opportunity for learning from them. So I'll give you one example again from my work on checklists. Came across a surgeon who people were very frustrated with. They called him kind of the big resistor, and he was resistant because he didn't want to lead the checklist at the point at which he was supposed to brief the group about what was to occur in the case. So a very important piece of the surgical checklist is that the surgeon brief the people in the case, and he just really didn't want to do that piece, so they called him a resistor. So why? Why won't you do this briefing? Someone finally asked him. He said, you know what? I do very complex surgery, and I take the time before the case to run through that in my mind. And I'm washing at the sink, and I am scrubbing, and I'm preparing, and I think in my mind through every step of that case, and that's how I orient myself and organize myself and prepare myself for doing the surgery. If you interrupt that in order to have me tell others about what I'm planning, I'm afraid that I won't be able to keep the patient safe because you're interrupting my flow. And we said, oh, gee, well, thank you for explaining that to us. Maybe we can work around it. What about speaking out loud as you reflect on this as you're preparing? So let's not do it, let's not do it in the operating theater. Let's do it while you're washing your hands around the scrub sink. People will gather around you. Could you just speak it out loud? Oh, yeah, no problem. I can do that. So this surgeon in this facility was able to improve the use of the checklist so that the surgeon had no problem doing a briefing. And in fact, it was an incredibly thorough briefing, and the surgical team was thrilled to be able to really understand what the surgeon was thinking about in advance of that case. Another example from the same work on surgical checklists comes from a study that I did with a colleague in Peru. So he went down to Peru and he interviewed surgeons, and he noticed there was he had an opportunity to talk to one surgeon who really wasn't using the checklist either. Why don't you use the checklist? And he said, and this you have to recall, Peru is a very sort of male egotistically oriented culture. So it's a machismo-based culture. And so he said, I don't want to be embarrassed. I'm afraid of being embarrassed by using the checklist because I don't always remember the patient's name. And so for that particular instance, we were able to offer up we put up a whiteboard in the surgical theater with not only the name of the patient, the name of the case, the name of the all of the clinicians in the room. Those are all parts of the surgical checklist that this particular surgeon didn't want not to know, because he felt like it was important for him to be able to demonstrate a sort of encyclopedic knowledge of not only what he was doing and his expertise, but also of the people in the room. And so that simple whiteboard, it's actually an innovation we recommend now worldwide for the use of the checklist, because you shouldn't have to, it's not about memorizing the people in the room. It's about having that information at your fingertips in order to be able to talk about people and talk with people in a way that you're speaking about them directly. And so asking and knowing enabled that innovation around that intervention in the same sort of way. So resistance can be incredibly, incredibly helpful for the work. So that's our fifth. Relishing resistance is my fifth guiding principle, and the last principle, which is related to relishing resistance, I call count on coaching. So individuals and teams, everyone benefits from coaching. I don't care how good you are at what you do. It can be critically important to all of us getting better, and particularly team-based coaching, which calls us on the way that we interact with others. We don't always see it. So there are a couple of important guidelines around effective coaching. The first is that you can't coach every person and you can't coach every group. There needs to be a level of readiness around it. You need to have an agreement on what it is you're coaching toward. What is our goal? Because we need to know if we've achieved it. The coach, him or herself, is really important. It needs to be someone who, it can be someone from outside, but it needs to be someone who is both respected and respectful. So it needs to be someone who, if they make a recommendation, the people who are receiving that recommendation are going to think twice about it, and preferably to adopt the suggestions. And it needs to be someone who is respectful, because of course they're coaching very established, highly educated, experienced professionals. And in the coaching, the way they approach the coaching needs to be around guiding and facilitating a collaborative process that enables people, that focuses on coaching people to figure things out themselves. So adults learn really differently from children, and unless we're coaching others to come up with the answers themselves, they're very unlikely to adopt. So it's just one of those very basic guidelines around how to do adult coaching. I didn't bring the clip because I wasn't sure how it would go over, but one of my favorite clips to use when I talk about coaching comes from a movie called Monsters, Inc. by Pixar. And there is a scene where they use a simulator center, and the monster makes these terrible mistakes, and the coach screams and yells and says, what did you do wrong? What did you do wrong? And the thing that they did wrong was they left the door open so that the child might be able to cross back into the monster's world. But that yelling, coaching, screaming is completely ineffective when you're dealing with adult learning. It may be very useful for effective in a movie like that, but not at all effective when you're dealing with people. So one last slide, Feel Advanced, is just about how to perform coaching effectively. And this is, again, about language. But what we've found around effective coaching is that using a balance of advocacy and inquiry. Advocacy and inquiry is a methodology that was developed initially by Chris Argyris. It is an approach that has proven over time to be really effective. So saying things, if you think about that checklist example that I was talking about, I noticed that you're really not briefing your colleagues as part of that surgical checklist process. Can you help me understand why you're not doing that? I saw that you refuse to do the briefing. Can you explain why you prefer not to be involved in the checklist? I observed that you did this. What might you have done differently? So very important not to present in an objective way what it is you see, and then to ask with a real sense of curiosity about the reason why. Again, with that view toward any resistance can be informative, and even if you do think you know the answer, recognizing that it's critically important that not that you know the answer, but that they learn the answer for themselves. So I think that brings me to the end of my guiding principles. But just to review, so the first one around contemplating culture, make sure that the culture in your institution is your own. It doesn't matter if you can say all the right things because you've learned it from some book somewhere. It's really got to be a reflection of the culture that you've brought to bear as a group, and that you believe is the right culture for your organization. Exercising leadership, especially small acts of leadership that can lead to bigger changes. Focusing on the problems and the aspects of culture that you have the potential for changing by affecting those problems, because those small problems and the aspects of culture that you're able to change by addressing those small problems will add up to big change over time. Find ways to align systems and processes so that they don't undermine the culture change that you're trying to achieve, because inertia is such an important fact of life. Recognizing and treating resistance as real opportunity for improvement, and embracing with curiosity opportunities to learn from people who do demonstrate resistance to what you're trying to achieve. And then using coaching to help individuals and especially teams to learn how to do things better themselves. So hopefully that was helpful. I'm curious to hear your reaction to these principles based on your own experience. And I hope we have time for those.